Next up is complications to immobility. So complications that occur with immobility can happen with any patient with even the slightest of mobility issues. Be very aware of this potential. Some of this information will have been covered in lab, and it's going to be very important to know. This is the stuff test questions are made of. Probably the number one complication to immobility is thrombophlebitis. And that's an inflammatory process that causes a blood clot to form. And that blood clot, depending on its size, blocks one or more veins. And the most common area is in the legs. The usual location in the leg is the very deep veins at the back of the calf. When a clot develops in a specific location, it's called a thrombosis. So blood clot thrombosis. Be aware that any patient is at risk due to the change in mobility during hospitalization. People are just not as active as they normally are. Any patient having surgery, even if it's a shoulder repair or a tonsillectomy, is at risk due to the slowing of circulation during surgery due to the anesthesia, as well as the decrease in their mobility. Surgeries that occur below the waist have an even higher risk. Any patient with compromised circulation as part of their comorbidities is at risk as well. And any person who has a sit-down job where their knees are continually bent are at risk. So think truck drivers for one example. What you will watch for, or the symptoms or manifestations, are pain, edema, swelling, warmth, and erythema, which is also redness. And you're going to be watching for those at the site. And keep in mind again that the calf, the back of the calf, is the most common site. So be sure and check the back of people's calves when you have them in the hospital. Remember, the most common place is the back of the calf. And the best assessment will be to measure the calf and thigh circumference at the same location each day. Usually what that involves is putting a black Sharpie X at one location on the calf, and everybody starts there and they bring the tape measure around and measure their circumference. What you're going to find is patients often complain first of the calf hurting or being sore. And it's not just a normal soreness like you've been working out, it's an excruciating soreness, extreme pain, and it's not anything that they normally have experienced. Kind of jump off the bed pain is how some people describe it. Along with the pain, there might be swelling and warmth noticed as that inflammatory response kicks in. The longer it goes on and the longer into the inflammatory response, the more you're going to see the redness and the warmth along with the swelling. But remember, that first indicator is pain. Typically, the affected calf size, the calf increases in size compared to the non-affected leg. So you're always comparing symmetry. So you're going to look at the affected leg and you're going to compare it to the unaffected leg. Now you may be taught the Hohmann sign in health assessment for the identification of DVTs. Unfortunately, it's still being taught and done in some facilities. It is not accurate. This technique was developed many years ago before we had the current lab and ultrasound technologies. And what we found is that people with actual documented DVTs had a negative Hohmann sign. And what we typically would say is if someone has excruciating pain when we do the Hohmann sign, it's positive. It's a positive Hohmann sign for DVT. And what we found is people had a negative Hohmann sign, but they actually did have a documented case of DVTs. Something to keep in mind, but you will still see it. All right, so if you notice that swelling is occurring or the patient is complaining of pain in the calf, first thing you're going to do is notify the provider. Generally, the treatment at that point is to limit the patient's activity and get that leg up, elevate the leg. Any type of pressure, so should be avoided to that area, such as massaging the back of the calf because it hurts, or putting on SCDs. Any sort of active manipulation to that calf area when we're suspecting a DVT is a big no-no, because you're basically massaging it to break off the clot, and we don't want that happening. When you break off a clot, for the anything lower body, it comes up through the heart and goes into the lungs. So it generally results in a pulmonary emboli. If we have something above the heart level, like in the carotids, and a clot breaks off, then it goes to the brain, and it's called a stroke or a cerebrovascular accident or a brain attack. Any of those terms work. But generally, when we're talking deep vein in the calf, the area where that clot ends up is in the lungs somewhere. Now, clots are treated with a category of meds called anticoagulants. The first thing that we typically start with is heparin. And when you have a diagnosis of a clot, that use of heparin begins to thin the blood immediately. So you've got circulation flowing around the clot until the body can absorb it. Heparin is used short term, usually, until another anticoagulant called warfarin, and its other name is Coumadin, reaches therapeutic levels. So we don't typically keep someone on heparin for long term. It's several days to a week, and then we switch them over to warfarin. The patient is often on warfarin, which is oral. It's a tablet, for quite a while. It could be months, and sometimes I've seen it longer. Large clots, and the body's not going to readily reabsorb it, or we've got a very large clot that if it breaks off is going to be a very bad scenario. We can use a medication known as tissue plasminogen activator. Tissue plasminogen activator, or TPA, and that's a small t with a capital PA behind it. Those are so-called clot busting drugs. Many times we use a drug called enoxaparin as preventative. We want to prevent a clot from ever occurring. So with some surgical patients or people that are in bed for extended periods of time, we're going to give them a shot in the belly, and that's the enoxaparin, and the other name for it is Lovenox. And you will be giving that during the second rotation, actually quite frequently. And that whole thing, it's prophylactic. It is to prevent a clot from ever forming. Okay, so let's talk goals for a little bit. When we have patients with immobility, the main goal is going to be promoting venous return. And by promoting venous return, what we're doing is avoiding pooling or stasis of blood in the legs, which is the perfect scenario for developing a clot. Now, there's several ways to accomplish this, and you should have learned about these in lab. One is elastic anti-embolytic stockings, and the slang for that is called TED hose. Those are those white stockings that are very difficult to get on. We used to use them all the time. We don't see them used nearly as much because we've got other things like the SCDs. The TED hose specifically exert pressure on the leg muscles, which then promotes blood return to the heart. Now, remember with TED hose that these need to be measured to fit, and they are very difficult to put on. And like I said, in recent years, the technology has developed, and we now include compression devices that are sleeves that wrap around the leg, and then they're attached to a pump, and that pump inflates and deflates the sleeve. And you should be well acquainted with this after lab. And again, after lab 2, we'll revisit it again. Obviously, in addition to TEDHOs and SCDs, another thing that can do to promote venous return is get the legs up so we can position them. Get them up above the heart. That's going to help as well. So keep in mind that the best way to promote venous return is moving, and moving as soon as possible and as frequently as possible. That's the absolute best protection against clot formation. Now that's why you will always encourage your patients to move unless contraindicated. There's always conditions that mean we need to keep them in bed. Just general rule, get them moving unless you've been told to keep them still. Range of motion will help with that if they can't be as active as we want them to be. Fluid intake is going to be very important as well as frequent changes in position. So fluid, moving them. Again, TEDHOs, SCDs, IPCs, they all require a prescription. Compression stockings, however, do not. Now we do need to discuss one last complication to immobility, and that is the pulmonary embolism. I'm going to go into what that is exactly a little bit more in detail so that you're comfortable with it, because it can happen and does happen. And a pulmonary embolism is what happens when a clot or a thrombus breaks off and it begins to travel. The thing that you need to be aware of is that pulmonary embolism is potentially life-threatening, because what happens is that clot travels until it can't travel anymore, and the location it generally ends up is in the lower bases of the lungs. Now, if it's a teeny tiny clot, just a teeny thing, it could get way down into the lung bases, and the patient may complain of shortness of breath, and that's not necessarily a life-ending situation. But if you've got a fairly large clot breaking off and it's traveling to the lungs, it actually can block way up higher in the lungs so that we lose all of the lungs below the blockage. All that tissue begins to die. A friend of my husband's had leg surgery about 3-4 years before she died of a pulmonary emboli. She went home for lunch. She began to feel bad. She really was very panicky, called the police department, and that was actually just a couple blocks away because she worked for the city. They were there in a matter of just a minute, if that, and she had already died. They resuscitated her. It was a half a mile, 3/4 of a mile to the hospital. She coded again in the ambulance, and they brought her back twice more in the emergency room. The clot was so large that it wasn't compatible with life. Then my mother-in-law had a clot break off and go to the lungs. However, hers was not a deep vein. It was a little tiny clot that broke off from a varicose vein that found its way to the lungs. She just had some shortness of breath and wasn't feeling good. Went to the emergency room. They did the scans. She had a blood clot just like the other person, but she lived. There was really no danger with that clot because of the size of it. So keep in mind with manifestations, the signs that you're looking for. Number one will be shortness of breath. You're also going to see chest pain. It's possible that you'll see hemoptysis, which is coughing up blood. You're going to see a decrease in blood pressure and an increase in pulse. The pulse will become rapid. So notice that you've got a widening. So blood pressure is dropping, pulse is rising. And then one other thing that I don't actually have on the slide is it's frequently reported that these people have this impending feeling of doom and panic. They know they're going to die. We typically see that with a much larger clot. Okay, so let's talk a little bit about the complications that we see respiratory-wise and what the actions would be for that. There's going to be some similarities to what we talked about with just the deep vein thrombosis itself. So when we have a pulmonary embolism, typically we're going to be treating with thrombolytics, so clot busters, things that will break up the clot, and then anticoagulants. And remember that anticoagulants are all about thinning the blood. When you start to thin the blood, you're increasing circulation around that clot, and eventually, depending on the size of the clot, the body can reabsorb it. Along with the PE, how you're going to handle it, because we want to maximize their oxygenation, we want to position that patient in what is called a high Fowler's position. So if you look through some of your pre-class stuff, you should see the various positions that you can put a patient in to help with their breathing. High Fowler's is straight up. Straight up. So get them up as high as you can. The further that they're leaning back, the more their lungs are dependent on gravity, and they're fighting against gravity to expand. It would be very important, obviously, to get a pulse oximetry. And again, until you get this down cold, pulse oximetry is measuring the percentage of oxygen saturation in the blood. Typically, we would put on oxygen, so we would administer it. I'm not going to go into what levels we would put them on and what type of masks we would put them in. That'll be covered when we get to respiratory. Another thing that might be done is to prepare what's called a blood gas analysis. That's a blood sample that is taken usually from the wrist in an artery. So we want to measure the oxygen level, the carbon dioxide level, the pH, the bicarb, that's what I was forgetting. So pH, oxygen level of the blood, carbon dioxide level of the blood, and bicarb as well. And that'll tell us how they're doing. And blood gas analysis is going to be a test that we'll look at more in depth when we get to fluid and electrolytes and respiratory. It's part of acid-base balance, and Tammy will talk about it in patho. And we're going to be monitoring very frequent vital signs. And when I mean frequent, it's really going to depend on the situation. It could be every 5 minutes, every 15 minutes. It just depends on how critical the situation is at